Yes, ma'am, but this is a lot easier to press, and then press like that. Or you do this one. This is mine. I think it says stuff.
Good morning. Is this working? Oh, good. It is. You can hear me. Hey, how are you? Thank you all for coming today. Really, really appreciate it. And we're very excited to have this first kickoff meeting. I believe they're going to shut our doors. I want to start first by thanking the Department of Corrections for loaning us this facility today. This is an incredible place that they have here, and we used this once before, and I said the next time I have a meeting where I need a large room where people can safely gather, I want to use this one. So they were very, very kind and gave us this location day, so I want to thank them for that. I also want to take 1 second to tell all of you that are on the panel or going to be on the panel how much I appreciate you coming today. The panel doesn't officially begin until January, but over the course of the next several months, a lot happens as we set up for 22 and for the start of ARHOME. And the presentations you'll hear today are really presentations that normally I'm given, but I thought as informational, it would be much better if the whole panel could hear these presentations and that you could ask questions and use this as a point to begin really getting ready for January when we launch. As we go through the presentations today, what we'll be focused on is, for the first time, our qualified health plans that we purchased for the expansion population, what's currently today Arkansas Works, will actually have health requirements in them. There will be improvements from baseline on different health performance metrics that each of the plans has to achieve. And under the law that was passed this last year, when we purchase those health plans, we have to set those requirements, we have to set those targets, and we have to set the actions that should be taken if the targets that aren't met. And the plans also have to present to us their strategic plans to improve health. So today what you'll hear is a first look at the baseline of what the Arkansas Works population looks like health-wise. And then you will hear each of the 3 plans that will be in the market next year present on their strategic plans for health improvement next year. We'll come back then in December. And in December, we'll take another look at the health of the population. We'll take a look at 2020 baseline information. And the Medicaid division will present to us their recommendations on the health improvement targets for 22 to start for next year. And at that meeting, even though we aren't officially a panel, I will ask all of you, if you wouldn't mind, to take a vote to let me know how whether you support those targets or whether those are targets that we need to modify. And then come January, the panel will officially start. And in January, once we officially start, we'll meet quarterly. And we will follow both the health improvement targets and how those are tracking. But we will also follow the economic health of this population. And we will be tracking then to see what's going on in terms of really the work with the population to see if we are also able to improve their economic standing. So there's a lot around this that will go on, but today's meeting kind of gives us a look at the baseline of where we're starting from. Okay, so with that, if we could just start by taking one minute and just quickly go around. It is a large panel, but if you wouldn't mind, there are bios on everyone, but if you wouldn't mind just introducing yourself for a moment, just so everyone knows who else is here. Right, and we'll start with you, Commissioner.
Insurance Commissioner. Jack Lehman, Chairman of Public Health in the House.
Hi, S.B. Frazier, Interim Director for the Arkansas Minority Health Commission.
I'm Erin Franks. I'm the Legislative Affairs Director for the Department of Education, serving on behalf of John Keith.
Jane English, State Senator. Linda Chesterfield, State Senator.
Dennis Smith, Department of Human Services.
Nell Smith, Department of Human Services.
Yeah, Bill Golden, Department of Human Services.
Sabrina Bratton, Arkansas Department of Corrections, serving in for Secretary Salton.
Mike Preston, Secretary of Commerce.
Representative Bruce Cozart, Chairman of Education on the House side, and I apologize early because I will be leaving you on in about 30 minutes. I have another meeting to go to.
Sacramento Secretary of Health.
All right, great. And then Dawn?
Dawn Staley, Department of Human Services.
Wonderful. So with that, we'll get going. I'm going to introduce first Dennis Smith and Nell Smith, no relation to each other, from DHS. And they have lead on this overall ARHOME program, and they want to spend a moment walking you through the program and the demographics on the population.
Thank you very much. We'll walk you through a relatively short deck, but we thought it was very important to give everybody some background. Not everyone is as familiar with what we have done in the new waiver proposal, so we want to walk you through that, and focusing specifically on the health improvement side of things. So Nell Smith, Assistant Director at the Division of Medical Services, will walk us through it.
Good afternoon. We are very excited to be here to discuss the Arkansas Health and Opportunity for Me program, or ARHOME.
Maybe everybody turn up their lights.
No, it's a computer, I think.
So ARHOME will replace the Arkansas Works program starting in 2022. We've been developing this program for over a year, and we're currently planning all the critical details of implementation. And this advisory panel is going to be very important for us in the development of ARHOME, and we're looking forward to working with all of you. As you may know, Arkansas Works is our state's Medicaid expansion program under the Federal Affordable Care Act, which was signed into law in 2010. The program covers non-elderly adults ages 19 to 64. Individuals qualify for the coverage if their household income is below 138% of the federal poverty level. So to put that in perspective, for a single person living alone, that coverage is about $17,800. And for a family of 4, it's about $36,600. For Arkansas Works, the federal government covers about 90% of the cost of the program, and that's a higher match rate than other Medicaid programs. Try now.
Let's try the computer.
So it's 90% match rate, and that's higher than the typical 70% match rate that we receive outside the pandemic. So Arkansas Works operates as a waiver program because we've set up our Medicaid expansion a little differently from what the Affordable Care Act established. And we're using Medicaid dollars to purchase private health insurance for our Arkansas Works members. So the current Arkansas Works state law and our federal waiver expire at the end of this year, so we needed to renew those authorities to ensure the program continues to serve our clients. And thanks to many in this room, the Arkansas General Assembly passed Act 530 to replace the Arkansas Works state statute and authorize DHS to apply for a new 5-year federal waiver. We've also submitted a new waiver application to CMS and are awaiting feedback. So currently, we have about 325,000 clients enrolled in Arkansas Works. Our enrollment during the public health emergency is obviously significantly higher than it typically has been. We're keeping many more people enrolled during the pandemic than we normally would to ensure that people can get the care that they need. Just under 1/5 of the state's non-elderly adult population received their health care coverage through Arkansas Works. And the total expenditures for the program for state fiscal year 21, which just ended, totaled about $2.5 billion. So now let me tell you a little bit about ARHOME, beginning with what's not changing. Individual eligibility is staying as it is. The program will continue to serve low-income, non-elderly adults. And the foundational structure of the program will not change. We're going to continue using Medicaid dollars to purchase private health insurance. And we'll continue drawing down that 90% match for ARHOME. But we'll be adding a number of new features to address 3 overarching goals. And the first and most importantly is we want to improve health outcomes. Arkansas Works has been very successful in providing health coverage for more people, but we continue to struggle to improve our state ranking in health outcomes. Currently, we rank 48th overall among all the states, and that's basically where we've been for years. So we want to make sure ARHOME is about more than providing health care coverage. We want to make significant gains in improving health, and we're particularly focused on these 4 areas: maternal and infant health, rural health, behavioral health, and chronic disease. We know that a significant amount of research that has shown a clear relationship between poverty and poor health. So the second goal of ARHOME is to provide opportunities to help people move out of poverty through employment and education. And third, we want to slow the growth in spending for the population enrolled in ARHOME, while also maintaining the significant financial benefits of covering members through qualified health plans through the private health insurance carriers. So we're implementing some new features with ARHOME that will help us achieve those goals. And the advisory panel will hear much more about the changes we've got in store with the Economic Independence Initiative and our plans for the Life 360 homes, the new component that we're calling the Life 360 homes, in the coming months. But because the focus of today's meeting is on improving health quality metrics and setting health improvement targets and your role in that process, I'm going to focus on those this afternoon. So the first major change with ARHOME is that we will hold the health plans accountable for the care that their members receive. This is the first time in the history of the 8-year expansion program, where we've held the health plans accountable for meeting annual health targets. We'll calculate the health plan's performance using national health quality metrics, those that are used to measure Medicaid performance. The metrics will help us determine how the health plans are doing in terms of their members getting preventive screenings and needed treatment, and will also set performance goals that carriers will be required to meet. In a minute, you'll hear from Dr. Golden, and he'll describe how the Arkansas Works program and the individual insurance carriers, how they're doing on those measures. And he'll give you the baseline data against which we'll measure all future performance. So health plans will also provide incentives to their members for participating in health improvement activities. For example, they might provide a gift card or waive premiums for anyone who gets their annual flu shot or preventive screening. And health plans have also been required to submit strategic plans outlining how they'll improve health outcomes among their membership, and they'll present those strategic plans today. So we're measuring the health plan's quality of care, and the plans are developing their strategic plans for how they'll make those improvements. But Act 530 also authorizes us to use financial penalties to absolutely ensure that carriers really work to meet those targeted metrics. So we've established a framework for the carriers in terms of what they should include in their strategic plans, and we allowed some flexibility in their plan design, but we spelled out a few things that they needed to include. And so these are the things that you may want to listen for during their presentations later. First, we asked them to describe the activities that they're planning to undertake to support health improvement and economic independence. We asked them to describe the activities they're undertaking to meet quality and performance metrics. And we asked them to describe activities to improve health outcomes for these populations. And we asked them to describe the initiatives for improving health outcomes in rural areas. We also required them to develop incentives that focus on driving improvement. And they could offer incentives to their members or to their providers, but we asked them to make sure that they included the incentives for health improvement among the populations listed on this slide. And we asked them that they at least offer one incentive to encourage preventive care. And of course, an important new feature of ARHOME is this panel, this oversight panel. Act 530 created the Joint Executive Legislative Oversight Panel to monitor and guide our work. And the panel is an important part of ensuring transparency in our program operations and stakeholder involvement. This panel will meet quarterly, and two of your primary purposes are exactly what we're doing today. First, you'll review the carrier's annual strategic plans. You'll hear about those strategic plans a little later. We, as DHS, are required to approve the plans, so we'll take your input and your feedback on those plans, and we'll ensure the carriers incorporate that in their plans before we approve them. This panel will also review the performance metrics for each health plan and help us set the targets that the carriers will have to meet each year. And Dr. Golden will present next, and he'll provide the first baseline metrics we'll use in that process. You'll see the metrics that we have today, and in the coming months we'll add measures on birth outcomes and measures to show progress in changing individual income levels. So these next few slides will show different demographic breakdowns of the program, and I'm using snapshot data from 2019 for these. When Dr. Golden reviews the state's performance on quality metrics a little later, he'll be using data also from 2019, so I just wanted to mirror the demographic makeup that you'll see in the metrics later. So this first slide shows Arkansas Works enrollment as a percentage of the county population in the Medicaid expansion age group. So you can see that the highest concentrations, it's a little small, but you can see that the highest concentrations of Arkansas Works enrollees, the counties that are royal blue or turning blue, are in some of the most rural counties and where poverty rates are highest. And our population centers, Northwest Arkansas and Central Arkansas, generally have lower concentrations of Arkansas Works enrollees. And this is something to keep in mind when we review the differences in healthcare quality metrics broken down by rural and urban areas. The fact that Arkansas Works enrollees are more concentrated in rural counties is another reason that we've asked the carriers to address rural health in their strategic plans. A significant percentage of Arkansas Works enrollees are women, nearly 60%. That mirrors the poverty data where we see in Arkansas and elsewhere that poverty rates among women is higher than among men. And that's part of the reason that we're focusing on particular aspects of women's health, including during and after pregnancy. And our quality metrics include preventive screenings for women, including mammograms and cervical cancer screenings. This slide shows the breakdown of Arkansas Works enrollees by race. However, you'll notice there's a significant portion of our clients for whom we do not have race data. They've not provided that. This is an issue that Medicaid programs across the country are trying to address, and it's something we're thinking about a lot, especially in our goals in addressing racial disparities. But aside from that segment, we've got about 56% of Arkansas Works enrollees who are white and 19% who are black. This chart shows the breakdown of Arkansas Works enrollees by age group. And you can see that about 2/3 of Arkansas Works enrollees are under the age of 45, with 45 being about the midpoint between 19 and 64. So the Arkansas Works population has more younger adults than older adults, and the largest age segment being the 19 to 24. So this slide shows the breakdown of Arkansas Works enrollees by their federal poverty level. So you can see that more than 40% of Arkansas Works enrollees fall into the lowest FPL grouping. They're either not earning income, maybe because they're in school, or their household income is lower than 20% of the federal poverty level. So another thing to keep in mind about this population is that about 35% of our Arkansas Works clients have at least one dependent child, and children in the home obviously affects where an individual would fall in the federal poverty scale. So that is the end of the information that I have for you. Dennis and I and Elizabeth Pittman, our director for the Division of Medical Services, you can feel free to contact us anytime, and I'd be happy to take any questions. We'd be happy to take any questions.
This is very informal today. As I said, it's a chance for all of us to learn. So if you do have questions, just raise your hand and I'll recognize you and you can ask them whatever you'd like before we go on to the health metrics. All right.
Okay, with that, not seeing any questions, I've failed to walk you through the notebook that you all have. So you have hard copies of all the slides that are being presented today. And forgive us as we jockey around a little bit for the next panel to come up. But if I may, you just saw our presentation from DHS. The next panel, Dr. William Golden and Dr. Adrian Novella are going to join us. This panel was, this was our quality data panel. We had representatives from Dr. Joe Thompson from ACI was on our panel, Dr. Mick Tilford from UAMS, Dr. Lynetta White participated in the panel, and each of the QHPs, each of the carriers also were represented so we could outline our data and make certain that we were all counting it all the same way. Because as you'll see, there's a great deal of data that is available, so to make certain it's consistent all the way around. Then after Dr. Golden presents, we will call up the representatives of each of the three health qualified plans, and they will present their plan of what has been submitted to us from Blue Cross Blue Shield, Centene, and Oscar. So if our distinguished panel is ready to go next. Again, this presentation is 2 parts. There is the overview slides themselves, but there is also a grid that shows each of the 21, and if you will flip to your, I don't know if they're all the same color, but the baseline metrics. The first would be the 21 performance metrics itself. Those are too small to put up on the screen. So we won't put those up on the screen, but Dr. Golden will walk through a presentation, and we'll walk through the grid itself. Dr. Golden, Dr. Novello, if you're ready.
Good afternoon, everybody, and thank you. Dennis, are we on here? Yeah, we are. Okay. So we have a task today, this afternoon, to talk about performance measures. And what I hope to do during the presentation is to kind of give you a 30,000-foot overview about how we went about doing this, why we're doing it, where it fits, some basic understanding of some of the complexities we dealt with in creating the data. And then at that second part of the presentation, we'll actually get into some of the granular data and hopefully not make your eyes glaze over and make it meaningful and useful. So today we're not going to answer all questions, but hopefully we'll give you some context as to what the numbers mean, what you can do with the information when you look at it later, and as this panel progresses over the next year or two or three, how we can use the data to enhance the program and get better outcomes in our state. So I've been working with Arkansas Medicaid data for close to 15, 20 years now, so I have a pretty good understanding of some of the limitations and dangers about playing with health data. But in particular, what we now have beside some of the local uses and local creation of data, the National Medicaid Program, CMS, has created what they call a core measure set. And they've been having this in place now for a good 5 or 6 years, where they have standardized measures, very often developed by other folks such as the National Quality Forum, the National NCQA, and others, which use scientific or clinical research plus data techniques to develop measures to collect uniformly across the country, measures that have clinical meaning, that are feasible to collect, and then could have impact if we do something with the information. And so this has been a voluntary program for the last several years, but in 2024 it'll become mandatory, where every state Medicaid program will have to submit this data on an annual basis to CMS for the programmatic management. Now, having said that, even though things are not mandatory right now, the Secretary of HHS produces an annual report of all the measures and all the data that is submitted from all the states that are participating, so that everybody can see through maps and other things how different states are doing on the different measures. So when you do the standardized approach, there are enrollment requirements, there are definitions of what gets included as a person that passes the measure, what is included for things that are included to be measured. There's a lot of complexities to creating that measure. There are two ways of collecting the data mostly. One is they call administrative data, which is actually billing data or paid claims. And Arkansas Medicaid has a pretty good warehouse of paid claims data that we've used over the years. And that's fairly straightforward. We take the definitions, we go into the computer, and we can pull the information out and actually get numerator and denominators and get the measures. The qualified health plans and the other commercial payers have their own databases as well of paid claims. The other piece of information we can use is called clinical data, which is actually stuff we pull out of the charts. Now that gets really complicated. So it's like, was your diabetes controlled? What kind of numbers did every diabetic obtain in their own doctor's offices? Well, you can imagine that would require the doctor's offices to pull the charts, copy the data, submit the data, somebody then to collect the data, to tabulate the data. That is a lot of work and a lot of hassles for a lot of people. So we have tended not to do a lot of clinical data collection just because sometimes it's not worth the energy on some of those measures to go through all of that. Having said that, we're looking for new ways of collecting that data. So down the road, we might have new ways and easier ways that we can collect electronically, that we can then get more granular data about clinical outcomes on particular things like diabetes control, hypertension control. But it's been hard to date. So here's a good slide of what happened in calendar year 19.
Are you on a particular tab? What's the color code?
Okay, where is my presentation?
Tab is baseline metrics.
Okay.
That's the blue. I still don't see.
I'm not certain they're all the same.
Okay, there is a slide deck somewhere, I hope.
So here's the grid that we're gonna get to. Then
Okay, so
these
that's
big
not in there, I'm not messing, that's.
There's the presentation right after the grid.
Okay.
Okay. So, and the reason that we have calendar year, or we have 2019 data right now, is that that's what the secretary had us submit. So you have to get complete data to create the data. And every year in January, we submit this data to CMS. Well, obviously, in January of 21, we don't have all the data for 20 yet because it takes a while for the claims to come in. So we submit 2019 data, which we tabulate in the last half of 20, okay, to be submitted in 21. So it's a complete data set. And we can talk more about that as we talk about the data we present today. But as you can see, Arkansas is sort of in the middle. We're in the kind of dark green there on the slide. We submitted about the average or the median of what all the other states did. But you can see Idaho, Montana, North Dakota didn't submit any data at all. Maybe they think they're in Canada. I don't know. But they have a lot of work to do. And you can see Texas submitted more than we did. But for the most part, we have been active in the program and trying to collect data that's feasible and meaningful and give to CMS. Now, every state, as we do this, have their own barriers and things that can make data collection and tabulation difficult. So if you have fee-for-service, that's one kind of way of collecting data, versus managed care companies. They have their own data, so it becomes more fragmented and you have to work with more entities. Arkansas Medicaid fee-for-service, which is predominant, we have our own data warehouse. Is the pharmacy data in your own formulary, or is it to another company, the pharmacy benefit managers? That's just another person, another entity you have to deal with. Every state, every plan has its own coding requirements and own weird ways of asking people to submit claims. So Arkansas Medicaid has its own unique claim codes that say North Dakota or Maryland does not have, or they have their own weird clones. So you have to kind of, make sure everything kind of fits together and fits we had a measure a couple years ago that we looked horrible on until we realized that the national metrics didn't count the way we code. And we put our codes in, all of a sudden our measures tripled. So, there are all sorts of gotchas if you're not careful in terms of those kind of funny little idiosyncrasies in the data. Global billing. So we give pregnancy providers, obstetricians, a global payment. Well, if you have a global payment, that means there aren't bills for each visit in each service. So that limits what you can collect during the pregnancy. Different states, different places have different analytic capacities. We're very fortunate that we have good external contractors who can have stable, well-trained people who understand our codes and do that and work with them year in, year out, so we can get consistency in the data analytics. Some states try to do it themselves, and they have a very limited staff that sometimes gets poached. So that kind of limits what they can collect and what they can tabulate. There are identified and de-identified claims. You've heard about de-identified claims where you can't identify who the patient is because of HIPAA. There are measures we have to know identification of the patient, because to track that patient and connect them to a drug and connect them to a lab test, we need to have the entire picture of that patient. And finally, we have health information exchanges. We have a pretty good one now in the state, and we're starting to learn their capacities to collect data from patient EMRs and from other sources and provide new sources of data that we can then tabulate without causing new hassles for healthcare clinics, healthcare professionals, and even the commercial plans themselves and their staffs. Here's some examples of some of the data we have submitted. This is a map of a measure that we look very good on. Arkansas Medicaid, this is fee-for-service data. It includes the fee-for-service population, the CHIP programs, and a couple of small ones. It does not include, in this picture, the qualified health plans, because we didn't have the data then. But you can see this is the number of patients who got high doses of opioids without a cancer diagnosis. Arkansas Medicaid several years ago put in place a program to restrict the amount of opioids or the milligrams you could get per day for Arkansas Medicaid patients. And every 6 months we lowered it a little more. And so now those dark blue color of the Arkansas map in this map shows that we have one of the lowest rates in the country of patients getting high doses of opioids without a cancer diagnosis. Here's a measure we don't do so well on. This is cervical cancer screening, which is, looking at Pap smears. And you can see that Arkansas, Missouri, and Oklahoma have lower rates in their Medicaid population I've just described than our surrounding states. And here's one that we're kind of in between. These are patients that get follow-ups 7 days after being in the hospital for a mental health diagnosis. And here you can see we're sort of in the middle. We're kind of a green as opposed to the yellow states, Oklahoma, Texas, Louisiana, which are much lower than we are. And finally, here's one that's interesting. This is the rate of admission to the hospital for people with lung disease or asthma. And here we don't look so well. On the other hand, we have a lot more smokers in a lot of states. And I think it's interesting. Look at all the states that are in white. Those are states that didn't supply the data. And I was interested to see what Indiana does because they have the highest rate of smoking in the country. So commercial payers, they have their own measures. They have something called the NCQA. Managed care companies do this, and they collect these data as well on their own populations, so you can compare commercial managed care plans to each other. So as Dennis mentioned earlier, starting at about January, December, in the winter, we developed a group that met weekly for the last several months. And you can see it was the qualified health plans, folks from DHS, General Dynamics, other folks from our public health, ACI, SHARE, to begin the process of preparing this data. And so we had to basically combine and homogenize data from different insurers. So I've kind of talked a little while ago about how everyone's got their own codes, their own definitions. We want to make sure that we could take data from Plan A and Plan B and put it together with DHS data and have it all make sense and work together. So we could get uniform, data that makes sense and is consistent and fair to all the plans and all the professionals taking care of these patients. We talked about clinical data, what was available. We try to avoid chart audits. We look for alternative sources. Many of the qualified health plans can get data directly from commercial labs. So they're paying the labs to run, say, glucose levels, and they can get that data directly sent to the plans. But that's only good for about 65% of the population. It's not for everybody in the program, so there are gaps. So it's not perfect, but it's something. I'll leave it at that. So we now have some baseline data, which is in front of you. That's the detailed thing with lots of numbers on it. And it's for 2019 data. The good news is it's a little old, but we had a complete data set. But now that we learned with that complete data set, we can now develop the 20 data pretty quickly. So we are pretty confident that by the end of this year, in the next 6 months or so, we'll be able to have 2020 data, not just 19 data. The 19 data taught us how to get the data together to do it. And now that we've learned how to do it, we can now do it faster. And you can see, and we'll talk about this, This is slide 12. I'll go over a couple of what we measure, but you can look at statewide performance, you can compare plans, urban and rural, and different demographic subgroups. So what do the measures look at? And what are the measures? And a lot of these measures have been given to us by CMS. So one of the reasons we're doing this beside our own programs is that this is something that CMS is demanding that Arkansas submit as part of its waiver. So because they're expecting us to have a certain level of performance as well as a state getting a waiver for this expansion. So we're looking at things, and some of the items include use of contraception right after pregnancy or in general, and the types of contraception used, breast cancer, cervical cancer screening, chlamydia screening. And you may say, why chlamydia screening? Chlamydia is one of the major causes of undesired infertility. So that's one of the reasons that is being looked at, to try to catch that before people have unwanted infertility. Treatment of asthma, which is a big problem in teenagers and in adults. So appropriate prescribing, reduction in hospital admissions. Chronic disease management, admission rates for heart failure and diabetes, all cause readmissions to the hospital. The other set of measures include a lot of behavioral health. How well are we treating depression? Are patients getting the treatment? Are they staying on the treatment? Follow-up after an acute event, a behavioral event in the ER or the hospital. How quickly do people get follow-up? Do they get a Band-Aid put on and get left alone? Or do they have care to make sure they don't have recurrent episodes of severe behavioral health problems? Management of schizophrenia. Do these patients stay on their medications? How well are they adherent? How well are we tracking how they're doing? Problematic prescribing. Again, we showed the slide about high doses of opioids in patients without a cancer diagnosis. Another one is patients who are getting opioid or morphine-like drugs with sedatives like benzodiazepines, Valium, sleeping pills, which can be a dangerous combination. And finally, how well are we dealing with substance use disorders? Are we identifying patients with alcohol and substance use problems? Are they getting follow-up? Are they getting treatment? How many people are getting treatment? What kinds of treatment are they getting? And that's what you have on the grid. You will see on the grid there's variability. So we can see that there's differences between, right now we just have our first pass of data. So in the qualified health plans, you can see that patients who are in urban areas do worse for heart failure readmissions and getting substance abuse treatment. People, and they have less follow-up after behavioral health events. Black patients tend to lag in treatment of depression, tend to have less substance abuse treatment, less follow-up after behavioral health events. White patients tend to have lower breast and cervical cancer screening. And they tend to have higher use of benzodiazepines and higher admissions for COPD. And then there's some differences between the health plans. Not everybody looks the same. So Ambetter had a little lag in behavioral health and substance abuse treatment. QualChoice had a little lag in preventive services. And Blue Cross had higher rates in use of benzodiazepines or sedatives. Let me stop for 2 seconds. Adrian, you want to go over the grid to tell them how to look at the grid? And then and then after that, we'll spend a little time about how we're going to use the data to make the numbers better.
So I'm just going to walk you through it. You'll see that the measures, there's 21 measures here, and they're divided into 4 categories. So the gray lines that go all the way across are the categories. We have primary care access and preventive care, maternal and perinatal care, care of acute and chronic conditions, and behavioral health care. So as you walk across, you have the measure name, and then the standard abbreviation that CMS uses for their core set. And then the reporting category, usually this will tell you the age range. It's not always the complete 19 to 64 age range of Arkansas Works. Sometimes it's a subset. And then if there's multiple sub-measures within a measure, it'll tell you what it's talking about. Like, for example, if you look under the first one on maternal and perinatal care, contraceptive care for postpartum women, there's 4 different sub-measures there looking at whether the woman got contraception within 3 days, and then 60 days postpartum, and then whether it was a most or moderately effective contraception, or the subcategory of long-acting reversible contraception. So there's those 4 subcategories. Then the 4th column over, you'll see the overall calendar year 2019 Arkansas Works performance. And then you have three sort of benchmarks to compare it to. So the first one, that 2019 mean of reporting states Medicaid, that's what Dr. Golden was showing on the maps. So those are the states that have self-selected to report their measures for their Medicaid population. So that's the mean of those states that reported. The second column is for most of the measures going to be, it's the NCQA State of Health benchmark, and that's Medicaid HMOs across the country. For a few measures, these are the prevention quality indicators. It's going to look at it's across 48 states for this benchmark, and it's all their discharges, hospital discharges, and those are looking at admissions for different conditions. And then the third comparison, the 2019 Arkansas Medicaid non-Arkansas Works, that's also what Dr. Golden was referencing in the reporting that we've been able to do for several years now on the Arkansas traditional Medicaid population. So that's not Arkansas Works, and also excluding dual Medicaid, Medicare beneficiaries, but including all other beneficiaries. And then the remaining columns are going to break out the overall Arkansas Works performance by different categories. So first you have, I think you remember from Nell's presentation, we have most of Arkansas Works in a health plan, but there are some people that self-select as medically frail. So there's a medically frail benefit plan, and then a couple other small plans, one that people go initially into and one alternate benefit plan. So this just breaks it down by those in the health plan and those in the medically frail group. Then you see broken out by the 4 existing health plans, Blue Cross Blue Shield, Ambetter, QCA, and Qual Choice. Next by rural and urban, and you remember from Nell's presentation, we have about a 50-50 split of enrollees, but it's a greater concentration in the rural counties in the state. And then broken out by race, ethnicity. So we have just white, black, and then combining several categories into other, and then that unknown group, which in that 2019 snapshot you saw was about, I think it was about 18% of enrollees that we don't have race information on.
If I may add,
Explanation again on the urban rural. So what that means is 46.2%
of those enrollees in an urban area received the cervical cancer screening. Then 45.9% of them in the rural area received the screening. By race ethnicity, 45.3% received that screening. African American, 50.4% received that screening. The other race ethnicity category, 50.9% received that screening, and then 41% received of the those that did not identify the race or ethnicity received the screening. Senator Chesterfield, please.
I'm trying to figure it out. I got the urban rural. You got 45.3% white. You got 50.4% black. That's almost 95%. So you're not looking at it that way, and you
No.
got the other at 50.9.
Correct. So we don't add them to get
The total population itself.
the correct.
That of the
So
total population, there were 45.3% whites.
of the whites received it. Right.
Trying to get it in my head.
Okay, great.
Of the total, so 45.3% of the total white population
I got it.
received it, okay. The reds and the greens, I assume, are, red means we did not do as well, green means we did better?
That's right. The red and the green on the overall column, overall Arkansas Works, is comparing to that next column. So that's those states that chose to report on that measure for 2019 for their Medicaid population. So if it's red, we did worse than the average of this reporting states. Green, we did better than the average. So a couple more things just to note as you take time to look through this more carefully. So let me show you an example on cervical cancer screening. So you'll see that, so if you'll look across the qualified health plans, the 4 health plans, you'll see that averages out to maybe mid to upper 30%, right? We have 44%, 42, 31, and 30. And then you'll see that if you look at by benefit plan, the QHP is sitting at 47.3%. And so you may wonder, you would think that the average of the health plans would be the overall QHP. So for the by qualified health plan, we looked at the information known to each health plan. So, they know information once the person enrolls with them for the duration of their enrollment with the health plan. We also know that beneficiaries churn quite a bit between benefit plans and even between eligibility categories in Medicaid. And so the rest of the values represent what we as the state know about the person and their medical claims and enrollment history. So it's for each measure, for each percentage you see, it's going to be a different numerator and denominator that the state knows about the individual versus what the individual health plan knew about the person. So the 4 health plans are not going to average to the QHP value.
Yeah, I mean, somebody may be in the program for a year, but to be fair to the plans, they have to be in the plan for a certain period of time. So there'll be some patients that weren't in that plan for that period of time. Plus, they may have gotten the service before they got in the plan, so the plan's data would not have the event in their data set. So there are all sorts of ways that service didn't show up.
And then just one more thing to point out as you look through this. Let's take breast cancer screening, for example. The reporting category for that is 50 to 64 for Arkansas Works, because that's as high as the age group goes up to for Arkansas Works is 64. For 2 of the comparisons, you'll see it goes from 50 to 74. It's for the Medicaid HMOs and for our internal reporting that we do for non-Arkansas Works beneficiaries. So just note, when you're looking at those comparisons, we tried to pick a similar comparison, but sometimes it won't be exactly the same age range just because of that cutoff of the Arkansas Works eligibility.
Any other questions about the grid? Before we go to the next section, we can come back later as well. Let me move on. So one of the things that we can do is now the question is, what do we do with this data, these data? And we have been doing quality improvement projects at Medicaid for a while. You want to look for compelling data, good clinical science. So that's obviously what underpins a lot of the measures in the first place. Some of the measures look low because they haven't been priorities. And now this program is an opportunity for us to highlight a measure. We'll say one would be, say, like cervical cancer screening or substance treatment. We can then, make it much more prominent or important for people to pay attention to. Everybody has many things they can work on from day to day, and this would be a way of focusing attention on a particular topic. We'll have comparative performance. So how we as a state are doing compared to the rest of the country. How Plan A is doing to Plan B. How rural is doing to urban. How different demographic subgroups are doing to each other. There's all sorts of ways we can use the data to stimulate people to want to make things better. Sometimes it's just a matter of better systems. So when we put up the data that showed that patients were not getting follow-up after being in the hospital emergency room for an acute psychiatric problem, the question could be, who was accountable for that follow-up? Was it the hospital? Was it the ER? Was it the doctor? Was it the primary care doctor? There are all sorts of ways that patient can fall through the system where nobody is really taking accountability or responsibility. And this is an opportunity for us to come up with better ways of capturing people so they don't disappear and then become a recurring problem with their health. And then there are all sorts of interesting financial incentives we can use. We can do financial incentives to plans. The plans can do that to the health professionals that work with them or with the patients themselves. So, years ago, I mentioned this to Dennis the other day, there was a guy named John Eisenberg who passed away way too young. He talked about the voltage drop that happens in healthcare. And you have a good idea and you have some data, but as you start to go through the system about patients getting involved, people get insurance, people go to the doctor, people have other priorities in their lives. The importance of the measures start to go down every time you start going through the system. So it gets harder and harder to make an event happen because people get distracted. There are just all sorts of ways where, if you will, the fire on the burning platform gets smaller and smaller as you go through the system and you go down to actually where the patient is in their home. So there are data limitations. The care gap's not prioritized. Sometimes the patients aren't interested. I can tell you, I have in my practice lots of patients say, I don't want to do a mammogram. I have no interest in it. Let alone, hey, we can talk about COVID vaccinations. I mean, a lot of people don't want to do that. So, or get flu shots. They just don't want to, so there's a lot of issues in that regard. And then there are disorganized systems. Who owns the patient? Who owns the problem? How do you make this, who's going to take accountability and responsibility for making things different? So, you got to have data that people trust. You've got to promote new ways of providing the care and taking that data and thinking about where or how we are failing to provide the services that are important to make the data better. What constitutes effective care delivery? What kind of targets do you want to achieve? What are realistic targets for achievement? Who will be accountable for that target? How do you set the target? Is it make yourself hit the national average? Have a goal that you set that the state wants to become a leader in? Maybe some are easier than others. So I showed you the item about reducing the prescribing of opioids. That was a fairly straightforward administrative change we made at Medicaid. We just changed what could be distributed at the point of sale in a pharmacy. Otherwise, it would be flagged, and the patient and the pharmacist would be told that this prescription doesn't get paid for. Get a new prescription. Not all targets are that easy to implement and to fix. The data can also help us create new policies, new programs, new benefit programs, maybe opportunities for ARHOMEs to be part of the solution for improving care. I have at the bottom of this slide different ways you can use financing, and we've done this with our patient-centered medical home. We use average performance to qualify doctors' offices to be eligible for big bonus money. So if you don't pass the average numbers, you're not qualified for the big bonus dollars. The big bonus dollars are targets we set for excellent performance. In the last year or two, we have put in a new item for minimal performance. So medical homes that don't meet the 10% of, that are at the bottom 10% of performers, we have actually threatened them with their participation in their PMPMs as being medical homes. And you know what? That has actually been extremely motivating. So we're going to be reducing gaps. We have aspirational goals, and we've talked about how to set measurements for change. And so finally, this is all about opportunities. We can create more comprehensive coordinated care. We can identify priority topics, satisfy CMS, reduce variability of care within the state, improve our rates compared to national measures, and ultimately we'll have better health in our communities. So that's the big picture. We've given you some 30,000-foot ideas. We've also given you some very granular information on the grid. So we hope that you find this useful and that you'll be able to use this for our discussions in the months ahead. Anybody have any questions or comments?
Dennis, could you describe what they're going to see in December in terms of the next round of data sets
Sure.
and the types of recommendations?
I am guessing, and I don't want people over in the corner throwing things at me, that we will begin to have 2020 data. And so that'll be much more in line with what we'll do for benchmarks. As I said before, the 19 data got us off the ground, got us to homogenize the data, got us confidence in what we're collecting, and now we're going to use those techniques to create more current data that we can use for benchmarking.
We will also specifically have 3 measures on maternal outcomes in terms of births that we're working with Dr. Romero's Department of Health to collect data off of birth records. So maternal health is extremely important to us, so we will have 3 different measures on birth outcomes. And then we will also have measures on, again, setting a baseline. This is setting the baseline for where we are. Then we'll also have it on economic indicators as well, in terms of where people are at a percentage of poverty. And again, one of the stated goals is to help people move up the income ladder. So we'll have baseline data on those as well.
And in December, since we will actually also have the department's recommendation on where to set the targets for the health plans for next year, we're going to provide all of this information to the panel a week ahead, is my understanding. So you will have a chance to actually review the 2020 health metrics. You can see the change from 2019 to 2020, and you can see what the department is going to recommend for targets that would be included in our agreements with the health plans for 22, for starting in January. So you'll have time to look at all of that information before you come to the meeting to ask, to go through it and ask questions. Okay.
Great. Well, thank you very much.
We will take a very quick rotation through. So we thank Dr. Golden, Dr. Novella for the presentation. We're not going to take a formal break, but if you do need to grab a bottle of water or a snack, please do so. We are going to bring the health plans themselves up for them to present their strategic plans. So we've got Matthew Van Netta from Blue Cross Blue Shield, Kim Suggs from Centene, Tamara Ward from Oscar. If those 3 lucky contestants want to come up, we will get you set up. I think Nell can bring up we'll go in that order. I'm going to keep time, so I'm going to keep you strictly to 10 minutes for your presentations. We'll go through each presentation, and then we'll open it up for questions.
And Dennis, when we come back and before you start, either at the beginning or when you get to Oscar, most of the group has not met Oscar, so you will want to take a moment to do that. No, I'll get it. Thanks. You wait.
a chance to grab a drink or a Powerball.
Powerball? Where'd that come from?
Power bar. Well, we're in our intermission here. I wanted to thank Kendall Rogers and for organizing the event, putting everything together. The ladies in the office, Courtney Brown, Claudia, Dominique, who did all of the preparation to have such a nice meeting today. So we want to thank them for a great job.
And Amy, Webb, and Keith Metz and their team.
Amy Webb and Keith and everybody. Keith is there? Okay. Okay. All right. You ready, Matthew?
I'm ready.
All right. Clock is ticking. Go ahead.
Well, thank you everyone for having me and allowing me to speak on behalf of Arkansas Blue Cross today. I will jump right in for the sake of time. So our program and our strategic plan is really broken into those 6 strategic goals and addressing each one of those. But comprehensively is how we want to approach our members from a true population health standpoint to ensure that regardless if it's a social determinant issue or if it's a healthcare issue and where we need to address gaps in care, that we're treating our members fairly and we're making sure we present them in a way and help them achieve those target goals when working with our providers and making sure our community resources are in place to be able to really have a round and holistic manner with which we treat our members. Specifically, when we're talking about those goals of the program, and we paired these 3 initially together because when we're talking about how we address preventative care screenings, how we talk about maternal care and overall behavioral health care, it really is dependent on a lot of ways our data analysis. It takes a lot of strategic data analysis and analytics for us to identify those gaps in care, make those available for our care managers and our social workers that are throughout the state of Arkansas and are really dedicated to improving the health outcomes for our members. And then working with our provider partners to ensure that they have that data available to them. We mentioned share earlier, that data interchange. That has been a great opportunity for us to partner with our providers throughout the state to exchange data in a meaningful way where historically that was a challenge for us. So having that ready-made access of data for our providers allows them to understand more the members that they're seeing on our behalf. And really it's a cornerstone for what we're trying to achieve by leveraging our primary care partners. And really that is the focus of where we think it really starts. Addressing those quality initiatives that Dr. Golden and others mentioned, without that primary care as we're the linchpin for that, it's very challenging to do so. So having our care managers help our members find that appropriate level of care, identify that primary care physician in their community is really where we start and how we want to address goal number 1. We'll do that through incentives. We'll do that through education. We'll do that through digital tools, apps, our website, and other means with which to engage our members so that we give them the best opportunity to have an opportunity to close those gaps, but more meaningfully have better health outcomes. For our maternal and child outcomes, to improve that particular goal, we have a subset of our care management team that we call special delivery. Those group of individuals, those nurses, are dedicated to working with all of our moms-to-be so that they have access to OB appointments so that they can find providers in their communities, so that they can also have someone to talk to, ask questions to, understand the process, especially for first-time moms. That's true for all moms as well as high-risk moms, and that's obviously a much more challenging population. That's something that really number 1 and number 2 lead into. What we would ultimately like to do is to work with our members so that they do not become high risk when they do become pregnant. So there's a little bit of a chicken or the egg that we always want to focus on, and that gets back to the holistic approach with our members that we want to take. Additionally, through technology, we're able to do a lot of different things that we couldn't have done even 2 or 3 years ago. Through the use of a new app that we've launched, our members have 24 access to care that they can address at any time, whether that's education and I have a question, or it's between OB appointments. They have an opportunity to be able to do that in a meaningful way. And having that tool at their fingertips through their smartphone is a very, very powerful option for our members. And goal number 3, in terms of improving behavioral health, finding that appropriate care is extremely important when it comes to those comorbid populations. And over 50% of our population right now in Arkansas Works has both a behavioral health and a medical diagnosis. So those members are dealing with quite a few different things, and it's complex for our providers to be able to manage both of those at the same time. Again, our care management team is really engaged with those members and help coach those members on what their options are to find that appropriate level of care for them so that they can manage both those behavioral health issues or substance use issues that are often tied with social determinant issues as well, to again make sure that they're addressing health care in a very holistic manner so that they understand what opportunities they have in their communities. I'll go back again to technology. Since those opportunities are limited in some areas of our state, having opportunities at their fingertips to be able to access telehealth, to be able to access information and work through some of those more complex issues provides additional opportunities that, again, we didn't have just a few years ago. Moving on to the next slide, and really these other 3 goals are grouped together for an important reason as well. So improving where the quality for target community investments and where we talk about our members improving their lives, really we're talking about in a lot of ways the same things. Being an Arkansas company and employing Arkansans all across the state, investing in our community is something that's always a passion for Arkansas Blue Cross and has been for a number of years. Because we are Arkansans, so investing back in our state is really a no-brainer for us. There's too many to list in terms of what we would like have done or would like to do in the future, but our Fearless Food Fight that we did that made 1.1 million meals with local food pantries, and then our COVID work that we're doing right now in Vaccinate the Natural State to do both education as well as work with provider partners across the state to do COVID vaccine clinics. These are just a few things of how we want to invest back in our community and why it's important for us to do so, because it does ultimately build up our members and Arkansans everywhere, and that's our main goal. And really that plays well into goal number 5 and goal number 6 as well. And when we talk about how we can improve the lives and lift up our members from where they are right now from a poverty perspective, incentivizing them for what they need to do, and really help them achieve where they stand right now, whether it's to improve their level of employment or gain employment. We're going to promote them to have additional education opportunities, whether that's through the Department of Education or Department of Workforce Services, to really incentivize them and take action on their behalf. And then the last goal there is to reduce health inequities and outcomes in rural populations. We recently promoted one of our medical directors to oversee our health equality and public programs. We think that's a critical position for us to be able to take that data, really dig into it, and figure out where in our communities we can really make an impactful difference. So that's something that's going to take time, but something that's a priority for our organization, something that's going to be a key focus of ours in 2022. I think I'm right up against time, so I will wrap up by saying our tactics for success, again, are really to incentivize our members in terms of healthy behaviors, take a multifaceted approach in terms of how we deal with health outcomes, and make sure that we give our members as many opportunities as possible to improve their state of health. Thank you very much. I appreciate it.
Thanks, Matthew. And again, we're going to hear from all, if you want to stay here.
Yep.
If you want to switch seats, and we'll get Kim. So if you remember on the grid, Kim represents Centene, but there are actually 3 plans, Ambetter, QCA, and Qual Choice on the grid. So all of those are 3 plans, 3 products that Centene brings.
Hi, I am Kim Suggs. I am the VP of Operations for Arkansas Health and Wellness, which is actually the local name for the Centene Health Plan here in Arkansas. And as Dennis said, we represent 3 different QHP offerings, but we will approach those 3 in the same exact manner. I have actually been with Arkansas Health and Wellness for just over 24 years, so I've had the opportunity to work with the AR Works program from inception, and excited to be able to continue the work that we've done with this population as it transitions to ARHOME. Our strategic plan really focused on the first two program goals that Dr. Goldman outlined earlier. One, to improve the health outcomes of individuals, our membership, especially in the area of maternal and infant health, rural health, behavioral health, and those with chronic conditions. In addition, providing incentives and targeting that young adult population to assist them in moving out of poverty and up the economic ladder toward independence. So we'll first take a look at the use of incentives. We at Arkansas Health and Wellness today have several incentive programs already in place that target populations in specific areas of quality and improvement and gap closure. Those incentives include member incentives, one in the form of a program we call My Health Pays, where members earn points for completing healthy initiatives. These points can then be used to purchase health-related items in an online store, or they can actually convert to dollars, which allows that individual to use those dollars to pay for other health-related type activities. They might be co-pays, any type of member premium, and then even utilize those dollars to pay utility bills or perhaps for transportation or childcare. These are just examples of member incentives. These can change annually. Typically, we set them annually, and we target the initiative we are hoping to improve from an outcome perspective. We also have a couple provider primary care incentive programs that we run today. These programs are really targeted to the primary care offices, and they target their population and gaps that exist. So through data analysis, we're able to determine where those gaps are, provide that data to the providers, and then once those gaps are closed, we're able to see that as well through our data analysis capabilities. Providers are then rewarded through an incentive program for closing these gaps. So much like Dr. Goldman outlined, there are different levels. So the more successful a provider is, the more incentive they can actually earn. We're also exploring a new incentive program, one that would target behavioral health providers, much like the primary care. So we'd look at members that are high acuity, seeing the behavioral health provider, and it would incentivize them for a set of outcomes in a similar way. Now we'll look at the possible use of incentives toward assisting members to achieve that economic independence. Arkansas Health and Wellness will seek to partner with the Little Rock Workforce Services Division, as well as all their regional partners. And together, we would like to be able to offer a connection for our population to the services that they have available, the employment opportunities that are in the local and regional markets. And we can do that through direct mail, our social media accounts that we already have, as well as health fairs, career expos, and job fairs. We can co-brand these events in the community, and we can offer the entire community the opportunity to attend these events. So they don't necessarily have to be our members. They would be open to everyone in the community, but they would be co-branded, and they bring services that are in the community into a local area, co-branded with community partners. Oh, sorry. You can also see here, this is just an example of a previous health fair we've done, just how we send out postcards, notifications, letting members know what's going to be happening in their community, and also provide the incentives to encourage them to attend. So those might be drawings for laptops, iPads, or maybe even an opportunity to earn a Lyft gift card, something like that. And then we typically have flyers that we post around in the community so that everyone knows that it's available and open for anyone to attend. We'll also host a dedicated web page on our Am Better site specifically targeted toward the economic independence initiatives, to include information around job training, resources, etc. Obviously, all of these activities around incentives are really meant to incentivize individuals to close care gaps or make improvements in their own personal self-care, etc. So all of these items are typically measured on an annual basis. As we talked about, it's a lot of data analysis. It's gathering information from our claims data, from our lab data, chart auditing, everywhere we can consolidate data to get a representative picture of how our members have performed and how our incentives have encouraged members to improve in their health outcomes. This data will be collected and provided to DHS annually. Again, areas of focus are typically primary care, maternal care, chronic conditions, and behavioral health care. As we look at the individuals and from a maternity perspective, we have several programs that we are running today that target our new moms-to-be. First and foremost, we target individuals with a notification of pregnancy assessment. So we do all the data mining, we do our best to identify individuals potentially pregnant, and then we do outreach to collect information to help us determine who may be at risk. And we get those high-risk members into our case management programs so they can follow them throughout their pregnancy to assist them and make sure that they're actually getting the care that they need, the tests that they need, and they have the education to stay healthy. All of this is really a part of what we call our Start Smart for Baby program. In addition, it includes opportunities for community baby showers, which are really education opportunities in a fun way. They really are like a baby shower, except it's an opportunity for us to get in front of those new moms and educate them about their own self-care before and after delivery, as well as caring for a newborn. I got ahead of myself. We also offer incentives for individuals to participate in all these programs. So we've really learned that sometimes it takes an incentive, right, to get individuals to participate. So offering opportunities for them to earn rewards for completion of each of these different areas. So maybe if they complete their NOP, they'll receive some diapers and wipes, all the way up to maybe attending a community baby shower where we can get that one-on-one personal attention. Might actually get a pack and play for attendance of those things. Moving quickly. We have opportunities for digital case management, which is literally an app on the phone that provides members an opportunity to get more educational information about various areas, maternity, behavioral health, and complex care. We have a program we call METS. It's Members Empowered to Succeed. This is a behavioral health program that looks at our behavioral health individuals with high acuity, pairs them with a case manager that can help them address the barriers that they may be facing, be it finding providers or social determinants of health. We also have a program called OPIEND, targeted at individuals that have a potential, that are in a potential category for an opioid addiction, or those that are currently maybe already experiencing a more use than expected. And then lastly, our individuals in chronic conditions. We have case management programs we run today, complex case management, behavioral health, maternity. We just talked about the digital, as well as some disease management programs. We're also looking to implement a social work program. That will be something specifically looking at individuals that have social determinants of health, targeted toward those individuals. And then as we look at our rural communities, we know there are racial disparities in behavioral health with our minorities. There's many reasons for that. Some is lack of availability. Some is really a belief it doesn't work. And then there's also barriers to actually getting to that care. Perhaps it's transportation or even child care. We will continue to address those areas, but one area we're exploring is a pilot that would help us provide some funding to rural health clinics to integrate some LCSW services into their primary care practices to do behavioral health screenings. This grants would help them hire a licensed clinical social worker and then allow them to enhance their current telehealth capabilities. So 360 degrees of impact. All of these programs, it takes all of these programs working together, incentive programs, case management programs, behavioral health programs, to really achieve that improved health outcomes that we hope to see. And then as those start to improve and we target those economic independence, we start to see those individuals moving out of poverty and up toward independence.
Thank you, Kim. And we're going to have Tamara Ward from Oscar to slide in here. Those of you who were part of the original legislation to create the waiver and the purchasing of private insurance using Medicaid dollars, one of those original objectives was to increase competition in the health insurance market. So we're very pleased that Oscar has joined, is applying to become one of the QHPs here in Arkansas. When you bring in new competitors, that shows that we have a healthy competitive market, which helps increase quality and lower costs. So we're going to give Oscar an extra minute and a half to introduce themselves, and then I'll start the clock. But welcome.
Thank you, and I thought it was an extra 5, but I'll take the minute and a half. Good afternoon, everyone. Thank you for having us. My name is Tamara Ward. I'm the Regional Vice President for Oscar Health and head of our insurance operations. We are delighted to be here. Today we'll take a slightly different approach to ensure that we educate you on who we are. We're the new kids on the block, and I want to give some time to really tell our story, but also share with you all our plan for Arkansas and the ARHOME program and why we think we can make a difference. So I'll start really with our history. We were founded in 2012 by our founders who had a horrible experience engaging with a very, very complicated healthcare ecosystem. And they decided to start a health insurance company powered by technology and provider partnerships focused on serving the member at the very core of everything that we do, which started Oscar Health. We're in 18 different states across the country, 291 different counties, 3 lines of business, and over 560,000 members who have chosen Oscar as their preferred health plan, and growing. In Arkansas, our focus is really in Northwest Arkansas and Central Arkansas. We have a core set of provider partners who we've chosen to partner with in the market to really start to better understand how do we create a deeper connection between the provider, the health plan, and the member to ultimately improve healthcare outcomes. We know that this is just a start for us, and that in 2023, our plan is to really, really expand statewide to ensure that we have proper coverage, not just in the urban areas, but also in the rural areas of Arkansas. And as we went out to really partner with different providers throughout the state, it was important for us to also align on incentives to ensure that our contractual relationships with the providers within Arkansas aligned with the healthcare outcomes that this group would like to see occur through the ARHOME program and that align with our strategic plan. As I shared with you in the very beginning, our focus has really been on consumer and member engagement and leveraging that engagement to improve healthcare outcomes. We've taken a different approach, I think, in investing in our providers, from everything to our onboarding, to how we develop our networks, and to how we connect that with our technology. And we take the onboarding experience as something that is very important. We understand that for many of our members, this may be the first time that they've ever had coverage. This may be the first time that they've ever interacted with a healthcare provider, or maybe they've done it for the last 50 years, but they don't really quite understand how a lot of this works. And so through our onboarding, we send out a welcome kit that helps our members really understand what they've signed up for, what type of care and access and quality of care that they have, and then ultimately connecting them with a care team. This care team is comprised of a group of 5 to 6 individuals focused specifically on the Arkansas market that is wrapped around that member and also includes a nurse case manager to help them navigate. So what does navigation mean? That includes navigating their network, what providers are in network, what providers are out, helping them identify providers that may have certain certifications to meet their cultural competent needs. It also helps them to find access to things that may not be easily accessible, whether that's finding transportation to seek services, whether that is additional maternity health benefits that are needed. That is their one-stop shop for everything. So they don't have to call 3 or 4 or 5 different numbers to figure things out. They have a dedicated care team that is with them through their entire time with Oscar, that learns about them as a patient, as a human being, as a family, and then allows them to help navigate throughout their healthcare experience. This care team is also there to help their providers. So the provider also has a one-stop shop of this dedicated care team to help understand what level of benefit, engagement, whether there are specific social determinants of health that are unique to that member. The provider also with ease has a one-stop shop to better understand what's available and what's not. And we found that that care team has reduced the anxiety of engaging in the healthcare system. It's built trust, and it's built a level of engagement that over time has allowed us to have some of the highest customer service and net promoter scores in the industry, but also building that trust with the health plan and with the provider and the member allows our members throughout the country to really, really adhere to the healthcare pathways that our physicians are prescribing for our members, that is ultimately leading to better engagement and improved healthcare outcomes. Through that model, we also provide services like telehealth. We offer a ton of in our app engagement, but we also understand that there is not a one-size-fits-all approach to healthcare. Some folks may engage with apps. Some folks may want you to actually come home, in their home to deliver that care. Others are most comfortable going directly to their physicians in a typical brick and mortar fashion to receive care. And Oscar is that flexible health plan that allows you to do them all and meets our members and our providers exactly where they are. We also leverage our technology to develop incentives that are unique to the member and unique to the market. Not every member may need engagement on breast cancer or colorectal cancer screening, but they may need us to really focus on chlamydia screenings with them. And so we're able to retool our benefit design and our incentive programs real time to really adjust for that. And we've seen that has allowed for a unique competitive advantage in the market, but it also helps to like I said before, build that trust with our member population. And it's very, very complementary to the services that our providers are offering in the market as well. Last but not least, I know that we have shared with you all and many others a very, very detailed strategic plan on all of the various different population health programs that we offer, whether it's behavioral health, whether it's keeping members healthy, specific programs around diabetes management. We've also just recently deployed a health plan specific to diabetes care that offers or removes the barriers to receiving treatment for many of our diabetics. Oscar is also definitely very focused on managing risk or emerging risk with our members. So before there is a chronic condition, engaging with them while they're healthy to keep them healthy, and incentivizing them to do so. And most importantly, focusing on our patient safety outcomes across multiple settings, whether it's in the hospital setting, the provider setting, or even through telehealth settings to ensure that there's the right level of patient safety for our members. I know that I've shared a lot. We are excited to be here, as I alluded, and looking forward to really making a difference in the community. One other point that I'll leave you all with before I conclude is that this is our first year here. We're going to learn a lot. We're going to adjust. We're going to listen to the market, listen to our providers, listen to our members to build a great sustainable plan that will be here in Arkansas for many, many years to come. We welcome the feedback and anything that we can do as a partner in the community to continue to invest in this population. We are open and excited to do so. So I hope I didn't go over my minute and a half. Awesome. Thank you, guys.
Okay. Thank you very much, panel. So please raise your hand or flip your card if you'd like to ask a question. And you can ask of any one of the panels. So again, this is Oscar, Centene, and Blue Cross Blue Shield if you want to address a question to one of them, or if you have a question that you want all of them to answer. Representative Flowers.
Hello? Okay, thank you so much. Ms. Ward, I am so impressed and compelled by the model, Oscar's model. I represent District 17, which is located in Jefferson County, and have served on several boards, commissions, and around health, and am always focused on doing a better job of providing health to our most vulnerable populations, particularly in South Arkansas, which is challenged by a lot of issues that ultimately affects our health. All that to ask, how is it that, and maybe this is also a question to DHS, but how is it that an insurance provider can submit an application for a program where we're trying to provide these resources for everybody in the state, but we are only focused on 2 regions in the state that also happen to be those that don't include our red county, and if you don't know about that, talk to somebody at the health department. Don't include our red counties, don't include minorities and rural Arkansans who are most affected by health disparities, and happen to include, if not pinpoint, are probably our wealthiest and best resourced counties in the state.
That is a very fair question. I think if you look at Oscar's growth throughout the country, when we enter into a new state, we enter in a very limited service area. The reason for that is that we want to get into the market and really learn. We don't want to jump into the market and assume that we understand all of the unique nuances throughout the state. I'll use Texas as an example. When we first entered into Texas, we started in Dallas and maybe in Austin. Over the last few years that we've really developed stronger relationships, networks, and products throughout a large portion of the state of Texas, including markets that are definitely multiculturally diverse, but also diverse from a perspective of rural and urban. Because of that, we're able to refine our strategies and our tools to satisfy that population. I'll give you a great example. In rural parts of Houston, Texas, and even Dallas, Texas, there are care deserts, per se, where there isn't enough behavioral health coverage for the African American community. We've partnered with behavioral health service providers solely focused on the unique needs of behavioral health care for African American members and beneficiaries in the state of Texas, that has allowed them to access care and barriers to entry to care that they've not had before. And so while our goal, as I shared earlier, is to expand throughout the entire state of Arkansas, we wanted to enter into the market in a meaningful way. We wanted to make sure that we understood the nuances and the requirements that you all would have of us under the ARHOME program to do it well, but it is 100% our plan to expand throughout the entire state once we've entered in 2022 for 2023 and beyond. And we know that as we enter into these two, I'll call them, market service areas in the very beginning, there will be certain needs there. There will be different needs in other parts of the state that we will then be prepared for. We didn't want to walk into the market and assume that we understood everything that the state needed from us as a health plan. We wanted to start, I won't say slow, but get a start and then develop and expand from there.
I don't want to monopolize, but just to respond to that, how do you come into a state with the intent of serving the entire state and start with a segment that really focuses on our most urban areas and our healthiest areas, and then expand in a rural, we're a rural state.
Mm-hmm.
So how do you expand and your initial process doesn't include engaging and serving in those areas that you will then have to serve? Like, how do you learn by not being in those areas?
For sure. So we've already begun the process of meeting with providers in rural parts of Arkansas. I think this year, because of COVID, that made that a little bit more difficult, as the receptiveness to meet in person, the level of pressure that many of our rural healthcare providers had during this last year, it was a little bit of a challenge to engage them in bringing on a new payer. Now that we hope that things are getting closer to a stable state, hopefully the variant will also pass. We are invested in the market, investing resources in the market to engage with our rural providers to ensure that we can develop a network that supports the members of the other, I'll say, counties throughout the state of Arkansas.
I'll get your card and we'll talk later.
Yeah, okay, then.
Thanks.
Secretary Gillespie?
This is a question for all three. When Nell did her presentation, slide 14, she showed our enrollees by FPL. And in that year, we had about 250,000 enrollees, and 100,000 of them had incomes between 0 and 20% of FPL. And I think all of you know, most of those individuals were showing incomes right at 0 in what we showed in our system. Many of them, one of the reasons for meeting at corrections is that many of them are people who were formerly incarcerated and had come out and really could not find work and were in the beginning stages of job training and trying to figure out what to do with their lives. So a lot of what you've presented focuses on the use of technology, and a lot of those individuals don't have access to technology, whether it's because it's rural or whether it's because of their poverty. So could you just talk to us for a moment about what's in your strategic plans that aims at those individuals that won't be able to use an app and won't have easy access to technology? Because we have to improve their health as well as a part of this. I mean, this is a unique population.
Let's just go right down the line.
Yep. Absolutely. I think, as I shared earlier, it's super important to meet our members where they are. Some will have access to desktop computers, some will have access to apps, some will have access to none of that, including transportation. And so we believe that with our care team approach, if we aren't able to get you engaged via phone, via app, via other tools, we can deploy nurse case managers, social workers, other support services in market to meet you at your home, to meet you wherever you are, to ensure that we're getting you engaged and understand that you have coverage and you have proper access to health care. So while we understand technology is great, a lot of us use it every single day, it is not for everyone. And within our strategic plan, we definitely outline how we will leverage in-market care management, in-market behavioral health services to meet members where they are.
Arkansas Health and Wellness is looking at a pilot social worker program to target just those individuals that you mentioned as part of the focus group. We fully recognize that those formerly incarcerated individuals do have barriers today of getting jobs, finding employers that will actually, hire them and trust them to work for them. So as we work with those individuals and pair them with a social worker, that will be their exact focus, is helping them with those social determinants of health, finding a job, finding a place to live. We even have programs that will provide them with some technology. If they can't afford a phone of their own, we can actually provide them a phone and then help them. That will then enable them to connect to that social worker when they need to. So certainly, we know we have a fair number of those individuals that are our members today, and targeting those with these special programs is how we plan to engage them and help them navigate the system.
We currently have welcome centers throughout the state. That is one means with which we're able to engage with our members throughout in Fayetteville, Little Rock, Pine Bluff, Hot Springs. So these members can go to those welcome centers, and although they can receive care there, they can also be referenced to our care managers. That is a pipeline that we have an opportunity for them to be able to get access to Arkansas Blue Cross and to our network of community engagement providers. We also have care managers that live in those communities all across the state. We have social workers that live in communities all across the state. So those folks are able to work with those community organizations, where those are food pantries, where those are the local DHS office there, to help those individuals find access to those activities that will allow them to get educational opportunities or to better where they stand from a workforce engagement standpoint. So really, I think it's our broad network of folks, both Blue Cross employees and those that we engage with, and that those folks are plugged into from a broader network perspective that allow us to touch those members in a meaningful way.
I think if I could, one of the things that comes out of today's meeting is, before the strategic plans are finalized, any things that we'd like to make sure are kind of highlighted or drawn out in there. And I think it'd be great if all three of y'all could just have a short section that highlights what you'll be doing around the rural areas where technology and access is much more limited. That'd be great.
Other questions for the panel? Representative Leahy.
Yeah, thank you. Sitting here looking at this, it's very complicated, but delayed. And you know, to tell you the truth, I don't like to be 48.
Thank you. People know me, I'm kind of competitive. I like to be in the top 10. I don't like to be 48th. And in order to move forward, we need exact goals and we need measurements, and I know that's what y'all are trying to do. But we've talked about 3 different groups that we feel like we need to address. Take folks that are coming out of prison and they have nothing to go to, and you have programs. What's the connection there? I mean, how do they connect? And also hospitals where you have new mothers, how do they connect? I mean, do they get assigned to one of these companies? How is that connection, or do they just come into this program when they have health issues? Do you understand my question there?
Yes, sir. There's a screening process that they go through to gain Medicaid eligibility to get into the broader program. And then if they're deemed eligible for the currently Arkansas Works program, then the soon-to-be ARHOMES program, then they can either choose a carrier or they can be auto-assigned to a carrier based off of that. And that's really our entry point into the program with those members. And then when they become our members, they're like any of our other members. And that starts the process of our engagement. That starts our sending them our ID card, their welcome packet, getting them onboarded as a member. And then based off of that, what we are able to learn from them, then we start talking about what their needs are beyond that, sir.
But I guess I'm talking to our departments here, but do we connect them, or I'm not sure I'm asking this question correctly, but do we connect them directly through DHS, or do they have to go out and apply? So these groups, you know, it may be difficult for them to apply for services. Do you understand?
The individual?
Yes, the individual, yeah.
Yeah, no, the individual actually has to apply. Now, a lot of individuals apply, I mean, you can apply at a county office, right? You can apply online, you can apply a lot of ways. But a lot of what you're talking about, I think, is someone who is uninsured and goes to the hospital, for example. And most of the hospitals and many of our providers in the state are actually set up to have people who then work with the individual while they're there to fill out their eligibility forms and submit those eligibility forms to us at DHS. And then that's how the person is then put into an insurance program. In this case, if they're in this eligibility category, as he said. And at that point, the individual is able to either pick a plan, one of these three next year, or if not, they're auto-assigned into one. And that's just simply who's up next to get which carrier's up next to get the person. So does that answer it? Okay.
Any other questions? Yes, please, Senator.
Thank you very much, and thank you all for being here. Just had a conversation earlier today about the silos of government, which preclude us really providing the services that we need to the individual. We got the plans coming from the health, from our providers. We have the Department of Education, it should be here. We have DHS. Until we decide we're going to remove the silos, separate the agencies, until we decide we're going to remove the silos which connect, we're never going to be able to do the wraparound services or provide those wraparound services that are essential to make sure people thrive. Not just survive, but thrive. So as we're looking at the programs, is there consideration for reaching out to the Department of Education so that we can talk to them about what some of those needs that they've seen in the public schools? What are we dealing, are you going to be dealing as directly with Cindy as you need to be in order to make sure that that is there? What about the Department of Commerce? Because if we just continue to provide services from provider to DHS to education, and nobody talks about the complexity and the completeness of the service for the individual, then we're still not going to be successful. Have y'all considered that conversation? Everybody's looking at me like I'm weird. And that's for DHS, it's for whomever. But I know our providers would benefit from having a better relationship with not only the parents, but with the students that they serve, because many times that's where the information comes from. If you've got parents who are in communication deserts, they're not going to hear about you. But if you've got communication through public schools, even though it's not the best communication system, many times that is the only way parents know about a program is if it's sent home by the child, sent home by the teacher or administrator by the child to the parent. Are we considering those and then talking with them about if the hygiene is better, you have a better shot at getting a job? If those things, those are the things that are troubling me, because even with all of your saying, I'm still seeing silos as a deterrent to getting us to complete health. And that to me is one of the critical things that we should be about.
So I'll make one comment and then let the three plans address, how you're planning to work outside of just the health system with the rest of the, components. And I think we did hear a little bit of that. In terms of trying to cut through the silos, that's one of the reasons for this panel. As you know, and we do have, I have to thank my counterparts. They have been really wonderful about not just wanting to take part in this panel, and you saw the secretaries here, and Secretary Key has his designee here, but outside of that, there's also a lot of work that's going on right now across the agencies, cross-agency, around how do we wrap around these clients and recognize that we've got to serve them holistically. So we've got a number of initiatives, and I will say everybody is coming to the table just really excited about how do we do that. Part of it's data sharing, which, you know, but we're making huge progress even on data sharing, recognizing that if we don't share the data on these individuals, we can't figure out how to work together about them. I'm happy to talk to you about it all you want offline, but I had conversations this week with Solomon Graves on some exciting things.
Thank you.
So,
We have time for one more question. Senator English, please.
So exactly what Senator Chesterfield is saying is really critically important. Education and workforce development is my thing. And it's so important, but I'm not sure you can ask an insurance provider to be the conduit specifically for how do we get people from, just like Linda's saying, from school to the next place in their lives, a trajectory. And sometimes we just put them in a program, and that's not a trajectory for their life. So I realize that you're having these conversations across agencies. I think that would be very important for us as a group to understand what some of those conversations are with some of these other agencies, and what is a kind of plan for trying to bring these organizations and these, because there's thousands of programs out there, but they all operate individually.
exactly.
And so if we can find a way to bring those people to the table too, so we can have that discussion about what is our plan.
Right. And I think we're all saying the same thing and in agreement, because we do think that the insurance companies, though, can be a player in this, a player among others, right? But definitely a player in it, because people don't always want to hear from government. And so whichever agency we are, or all of us together, we are government. But one of the things I like the most about this program is that the recognition that health is broader than just seeing your doctor and these health metrics, which are critical, but it is broader than that. And I do think in their strategic plans, they have all recognized that a big part of actually achieving the health metrics is going to be also helping people take a more holistic approach to their lives, and not just, making sure they get their labs done. We've got to do a whole lot more. So.
Let me thank the panel. We appreciate it very much. We're looking forward to working with you on refining your strategic plans, and we will continue our conversation. Secretary Gillespie, it's your close.
Just want to thank everyone for coming today. Oh, I think Representative Flowers has one more. Yes, these are yours. No, these are all yours. You can leave this if you want, and we will also email it to you if you would prefer not to take a hard copy. Kendall is going to email it.
Leave it, and then maybe as we get new information, it can be added in here. How's that?
We can do that if that's what you would like. All right, great. Okay. Thank you very much, and we will see all of you again in December.